Many insertion techniques have been documented. The manufacturer recommends the following insertion technique for the LMA Classic, Flexible, and Unique. The modern insertion technique describes using the index finger to insert the mask fully in place in one smooth movement. If these instructions are carefully followed, failure of insertion should rarely occur in any patient who is able to swallow food normally. Insertion is made easier by maintaining the sniffing position, as for intubation, and this can be done by using the non-dominant hand. Neck extension should always be avoided, as this can make insertion very difficult. However, it has been shown that the laryngeal mask can be easily inserted in patients with fixed flexion deformity. To drive the mask into position, we need to use the gloved index finger of the dominant hand, which should be placed at the junction of the mask and the tube so that the device is held like a pen. It should be noted that Dr. Brain is left-handed. As the index finger drives the mask towards the back of the throat, it must be pressed cranially upwards to maintain the mask in close contact with the palate. This will usually prevent the tip from folding over, and will distribute the gel over the surface of the mask. It is necessary to check that you are doing this correctly by looking into the roof of the patient's mouth at this stage. Do not release pressure, or the mask may lose its contact with the posterior pharyngeal wall and start to fold over. In order to drive the mask fully into place, you need to draw back the other fingers so that your index finger reaches as far as possible into the patient's mouth. Slight pronation of the arm is helpful in the final stages. The LMA Flexible should also be inserted using this technique. In order to demonstrate more clearly what is taking place, laryngeal masks were inserted into a cadaveric specimen in which a lateral dissection of the neck had been performed. Pressure must be maintained centrifugally as the mask travels around the curve at the back of the tongue. Definite resistance is felt when the mask tip arrives at the base of the hypopharynx. At this point, about 8 centimeters of the tube will typically protrude from the adult patient's mouth. Do not remove the index finger yet, but first grasp the tube with the other hand, applying a gentle inward pressure. Only at this stage is the index finger removed. The mask should stay in place and should not be moved or held while it's being inflated. Slight outward movement is normal as the mask positions itself in the hypopharynx. The manufacturer's maximum inflation volumes should not be exceeded. It should be emphasized that these are maximum values. Bearing in mind that cuff expansion may occur due to diffusion of nitrous oxide into the cuff, approximately half these values may be appropriate.